Good morning, everyone.
Good morning, madam.
Good morning. Yeah. Happy to be here on this academic feast. Yeah. Today's slide seminar, the Thesaurus slide seminar. I would like to say, like, before welcoming everybody, I would just say, like, why did it start actually? It is the architect behind this is our beloved Dr. Shashikala P, who believes in learning. Learning is an everyday process, and also learning comes only when we teach somebody. So the thought was to call the alumni of whoever is passed out from Davangere and also who's worked from Davangere. So the Davangere medical people who have worked in Davangere medical colleges as well as graduates from Davangere. So here I present to you this first slide seminar, that is the Thesaurus slide seminar, the slide seminar series 1. And I would like to welcome all our alumni who have joined in to this program, all the postgraduates and our colleagues, and Dr. Narayan Murthy, Professor HOD, SDM Medical College, and Basaveshwara Medical College, Chitradurga. So Sonam would be presenting the, she is a pioneer in Adnexal tumors. So today she'll be just taking on Pilosebaceous unit. And it's a proud privilege to welcome Dr. Sonam to this slide seminar. Now, we would like to have a small inauguration. Welcome one and all to this academic fest. Yeah, I'd like to call I would like to ask Dr. Shashikala Madam to speak about this program.
Thank you, Dr. Deepti. Good start. Good morning to all of you. So welcome all of you to this academic. So this is an opportunity to learn and listen from our past, present, future, you can say pathologists who are associated with us, an opportunity to interact with our own people. This I call it as academic feast, and I know, we have all become obese. Academic obesity has started with all these webinars going on, but since we have been having all 5-star hotel academic menu, I thought it is time for us to have a nice homemade recipe and enjoy it. So we have a lot of pioneers amongst us who can share their knowledge with the postgraduates and all of us. And this idea came to me long back, and Dr. Narayan Murthy, HOD of BMCRI Chitradurga, he is very cooperative, and since a long time he is also asking me to start some academic program where both the colleges could interact, jointly start some venture. And this idea, when I just put forth in front of our faculty, especially Dr. Deepti and Dr. Kavita, so they gave a nice shape to it. So Deepti has taken a lot of pains to start this, to make this come true, the dream come true. And now that session has started. For the first session, we have Dr. Sonam, who was our faculty. I'll say she continues to be our faculty, though she is not here on the roles of SSIMSRC. As Dr. Deepti said, she is a pioneer in Adenexal tumors, and so we have already given invitation to our past PGs who are all consultants in various places in India and abroad, and then our own faculty who were working with us, like as Deepti said, alumni. So in future, we have planned for one academic feast like this per month, and definitely we are going to see friendly faces, our own friends and whom we have not met for a long time because of this COVID. And so it's an online get together academically. So let us all interact, meet each other. And as I always say, learning should be enjoyable. So let us enjoy learning. So thanks for Sonam, who has accepted this invitation. And then Dr. Murthy, who is here, to give a nice start to it. So it's a joint venture now of SSIMSRC and BMC RI Durga. So thanks to all the pathologists and our alumni join to make this academic feast a great success. Thank you all.
Thank you, madam. We will proceed with starting of the session with a introduction to the moderator of today's session, Dr. Narayan Murthy. So we all know him, though we will just go into a little bit details of Dr. Narayan Murthy. Sir has started his career in pathology in 2000, and following that, he completed his post-graduation and he has done his MBBS from Adi Chunchandgiri Institute of Medical Sciences, Karnataka, and he has done his master's in pathology from Siddhartha Medical College. And from then he started his career, and he had also been the associate in 2014 period, and continues to be the professor and head of department of pathology date over more than 8 to 9 years. Sir teaches undergraduate and postgraduate students. He has 21 papers to his credit in various national and international journals. And he's also a consultant pathologist in Vasavi Diagnostic Center, Chitradurga. He has been awarded IMA KSB Presidential Appreciation Award and had been the academic term at Rajiv Gandhi University, Bangalore, and also been an external examiner at Mauritius Medical College, Mauritius. So with such a nice CV, I hand over proceedings the program with Narayan Murthy. We introduced Dr. Sonam, and then she would take over. So, welcome, sir, to moderate the session.
Good morning, all. Respected Shashikala madam, other faculties, senior faculties like Deepthi madam, Kavita madam, and Ramesh from our college, and also all the faculties of Basaveshwara Medical College and Basal. And main focus for this program is postgraduate students who are very important. Seeking the blessings of His Holiness Dr. Shivamurthy Muruga Sharanaru. Today, with the support as always from Dr. Shashikala madam and our team, madam, we are very thankful to you, and we are very blessed that we are associated with you. Even during the time of pandemic, we could connect like this. We always used to discuss we should start something for the PGs. Madam is always there for an innovative ideas. Madam needs no introduction. Madam, thank you for all support. Definitely such sessions will be useful. That too, with an idea of doing once in a month, definitely it will be useful for the PGs as well as staff to update ourselves. And thanks to all for creating such a wonderful platform. In particular, Shashikala madam and their team, and Deepthi madam, of course. Thank you for this wonderful platform. And let me introduce today's speaker, who is very good in Adnexal tumor, Dr. Nandyal. She is a professor, and she is the backbone of our department. She works very hard. Professor in our department. She did her UG in KIMS Hubli, and also PG from the same institute, KIMS Hubli. She has done 19 publications till date, and many are award-winning and very innovative papers like artifacts in histopathology or artifacts in cytology. So she is very good in those things, especially Adnexal tumor. Today's discussion definitely it will be beneficial for the PG staff members. I request Dr. Sonam Madam to please start the session.
Yes, sir.
Over to
You, sir. Thank you, sir. Am I audible now? Am I audible now? So, a very good morning, all. Thank you for the warm welcome and kind words, madam. So, it was my privilege to be associated with SSIMSRC. So, without wasting time, so let us begin the slide seminar. So, before we begin the slide discussion, I just want to brief about the basics of skin adnexal tumors. Since it was a very huge topic, today's session I just restricted myself to tumors of the Phylomatricoma unit. So we face a lot of difficulties when it is a skin adnexal tumor. There are various reasons for that, mainly because they are rarely encountered in the routine practice, and there are so many of them, both benign and malignant varieties, which are difficult to remember. The classification is difficult. The nomenclature is very complex, and it is also confusing. And also they exhibit sometimes morphological differentiation towards one or more adnexal structures. Also, one of the reasons is because they have a very non-specific clinical appearance, and also lack of understanding of the concept of the histogenesis, which is very essential for the diagnosis of these tumors. So there were various classifications proposed in the past, which required modification from time to time, mostly in the light of advent of recent ultrastructural and histochemical findings, and also reporting of newer morphological entities. So most of the adnexal tumors are benign. So whenever we, once we have determined that there is a epithelial tumor in the dermis, and if it is not looking like an epidermal one or a melanocytic one, then our guess will be that maybe it is originating from the adnexal structures. So these epithelial tumors at first glance, gives the impression of basal carcinomas or seborrheic keratosis, or even squamous cell and adenocarcinomas. Also, maybe they would have signed out in these names also. So basically, we have to develop and practice this algorithmic approach for these adnexal tumors on HND sections, which is very easy to follow without even depending on immunohistochemistry. So we know that SATs are classified according to the line of the differentiation into hair follicle tumors, sebaceous, and sweat gland tumors. So it depends on the location of the tumor and the distribution of the adnexa and the connection with the epidermis that we need to find them. Generally speaking, sebaceous glands are very easiest one. That is because of that important clue, that is whenever we see these vacuolated cells with the scalloping of the nucleus. Whereas these sebaceous gland tumors are a very large category, and whenever we find any tubular differentiations or any secretions in the tubules, and there is a decapitation or papillary structures, then probably we are dealing with the eccrine tumors. So in my view, hair follicle tumors are the most difficult ones, mainly because they have a lot of histological overlap and confusing terminology. The key to identify these tumors is whenever we see proliferation of the basaloid cells, have a nuclear palisading, or whenever we see this trichelemal type of keratinization in these tumors, or when we find the papillary mesenchymal bodies, shadow cells, or if the tumor is attached to normal follicular structures, then probably we are dealing with the hair follicle tumor. So clinically, if they are solitary, they usually cluster around the face and usually seen in the head and neck. But whenever they are multiple, of course, they are associated with various syndromes and also regional distribution of the adnexal structures should be kept in mind. For example, hair and sebaceous glands are there all over the body except for palms and soles, whereas the apophyseal glands are mainly concentrated in the axilla or enogenital region, and so on. Whereas eccrine glands mainly concentrated in the palms and soles. So without having the basic knowledge on anatomy, histology, and embryology, we find them very difficult to diagnose. And we know that this epidermis is derived from the ectoderm, whereas dermis from the mesoderm. Yes, and melanocytes and these cells come from the neural crest. So whenever during the development of the skin, usually when the epidermis is developing, there will be an area of crowding of these basophilic cells, which subsequently develop buds that protrude into the dermis, and they get associated with this dermal papillae, which help in the growth and development of the cells. And this all starts from the 4th month of the intrauterine life, where the primary hair germ, whenever it is developing, it protrudes downwards and forms a sieve-like invagination, and on its surface it develops 3 bulges. So the lowermost bulge is for the attachment of the erector polymer. The middle bulge develops in the sebaceous gland, whereas the upper bulge develops into the apocrine gland, depending on the regional distribution of the. So it is important that we have to, uh, you know, uh, uh, classify this hair follicle into 3 parts, or section the hair follicles into 3 parts. That is the lower segment, which has this bulb and suprabulbar portion, which starts from the base of the follicle to the insertion of the erector pili. And the middle segment, we call it as isthmus, which begins with the insertion of the erector pili till the opening of the sebaceous gland. And the uppermost part, we call it as infundibulum, which extends from the opening of the sebaceous gland to the follicular auricles. So this is the hair bulb on the histology, what we see. And let us know how the hair bulb looks. Okay, so this is the hair bulb. It has 2 things: the matrix cells and the papillae. So this matrix cells are basalloid cells, and they have a deeply basophilic cytoplasm. And also we see these germinative cells, which are kind of palisading ones, which are in close association with the papillae. So we have 2 types of cells in the bulb, that is the matrix cells and the germinative cells. So some tumors arise from these matrix cells, and some of them arise from these germinative cells. So whenever we see routine sections, try looking for the layers of the hair follicle. From the innermost, we have this shaft, which has a medulla, cortex, and cuticle. Then it is surrounded by an internal root sheath, which is again surrounded by the outer root sheath, which have a eosinophilic or clear cells, and then it is bound by a hyaline membrane, and then it is surrounded by a fiber sheath. So this is how the hair shaft looks in the canal. So it has a medulla which partially keratinizes, and it has a cortex which gradually keratinizes, and it is converted into a hard keratinous structure. So we have to keep in mind that every part of the hair follicle has its own way of keratinization. So outside the hair shaft, we have this inner root sheath, which is made up of 3 layers. And can you make out this inner root sheath is pinkish granules. So these are trichohyalin granules, which are the trichological counterpart of the keratohyalin granules, which we see in the epidermis and the follicular infundibulum. And outside this, we have this outer root sheath, which is also called as tricylemia, which is a layer of multi-layered cells. They have clear cytoplasm and the palisading of the columnar cells, which you have loaded with the glycogen. And it has a hyaline sheath, And this hyaline sheath is surrounded by perifollicular fibrous sheath. So when we see the hair at different sections, they look different. So if the section is taken at the level of the bulb, usually we see the papillae and the matrix cells which are admixed with the melanocytes. If we take the section at the suprabulbar region, almost all the layers of the hair follicle are seen. Suppose if we take the section at the isthmus, the inner root sheath is absent and the hair shaft is lying freely in the canal and it is surrounded by the outer root sheath. And if it is at the level of the infundibulum, the shaft is surrounded by the epidermis. So after knowing this brief histology and embryology, now understanding this particular classification of the hair follicle tumors, which is based on the histogenesis of the tumors, becomes easy because if we depend on the nomenclature, they are very descriptive and confusing terms, and sometimes they are inconsistent also. So here, this classification categorizes based on the anatomical part of the follicle, whose morphology the tumors will try to recapitulate. So starting from the uppermost part, we have the tumors which are arising from this infundibular portion, that is dilated epiderma, and then we have the tumors which are arising from the outer root sheath of the isthmus, like proliferating tricylemia tumors and so on. And then we have tumors which are arising from the hair bulb. Mainly, as I explained, there are two types of cells, the germ cells and the matrical cells. And then we have tumors with the panfollicular distribution, where the whole hair follicle is trying to be recapitulated in the tumors. And then we have finally the mesenchymatous hair tumors. So this is the normal terminal anagen follicle, and we have this hair bulb. So the tumors which are arising from the matrical cells are Phylomatricomas, and then these palisading germ cells which are biphasic in differentiation, like trichoblastomas and epitheliomas. And this is the perifollicular fibrous sheath, where so many tumors arise, like fibrofolliculomas and trichodiscomas. And this is the outer root sheath of the isthmus region, the tumors arising from these areas. So with this brief background knowledge, now let us move on to the first slide. So who is describing this slide?
Good morning, ma'am. I'm Dr. Samiksha from SSIMSRC. I'm going to describe this slide. Slide number 1. History given was 31 years old female with leg swelling since 1 year. Query sebaceous cyst. Grossly, it is a well delineated multinodular bit measuring 3.5 into 3 into 1 centimeter, and cut section shows multiple chalky white areas.
Okay.
You can tell.
Next slide.
Okay, once. Yes. Can you see the slides now?
No, ma'am.
Okay. Yes, now can you see?
On the same slide is visible, ma'am.
Okay.
Ma'am, can we present the PPT?
Stop share. Sonam has to stop sharing.
Now?
Ma'am,
No.
we start sharing our PPT from our side.
Yeah, yes, please.
Section studied shows two areas. Blue color area, basophilic cells are seen, and the eosinophilic area shows the squamous cells. This section shows mature squamous cells. Few cells show polycytic change, and few cells showing ghost cell appearance in where the nuclei is absent and only the cellular margins are visible. This section shows foci of melanin and sheets of ghost cells where only the nuclear margins, cellular margins are visible and nuclei are absent. This section shows sheets of ghost cells. This section shows foci of melanin with sheets of ghost cells. This section shows foreign body giant cell, which can be a reaction to the ghost cell or giant cell reaction to the ghost cell or the calcific areas. This slide shows areas of calcium deposition, that is calcification is done in this area. So all these features are suggestive of Phylomatricoma, also known as calcifying epithelioma of Malharbe. And the differential diagnosis can be tricholemal cyst or basal cell carcinoma. Thank you. Thank you, ma'am.
Yes, my screen is visible.
Yes, ma'am.
Yes, can my screen is visible? Yes.
Yes, ma'am. It is.
Okay. So yes, it was described nicely. So this is Phylomatricoma. So an example of the tumor which is arising from the matrical cells. So as the name indicates, it is a tumor of the matrix cells. So there are two cells, basaloid and shadow cells. So let us know about a brief history of these mysterious or controversial ghost cells. So these were first described in Phylomatricomas, and we do see them in a normal developing tube. And they are always epithelial in origin. Like any layer of the epithelium from the basal to the superficial can show this transition to these terminally differentiated ghost cells. So they don't have any intercellular junctions, and though they are dying cells, the cytoplasm is well preserved, and calcification within the tumor indicates the degenerating nature of the ghost cells. So there is a transition here from the basaloid to the shadow cells, and this transition is very gradual. Okay.
Right here.
Ma'am, please do slide share.
Slide show. It is done
Slide.
actually. Okay. Slideshow. Okay. Actually, it is little bit delayed. Yeah, now I think it is visible.
Yes, ma'am. It's visible.
Yes.
Yes.
Shall I continue?
Yes.
Yeah. So in this transition, okay, from the basaloid cells to the shadow cells, we are seeing there are five features to observe. So one is the size of the cell. So kind of these basaloid small with basophilic cytoplasm. As they undergo this transition, the size of the cell increases, and these basaloid cells are lying in one sheet of cytoplasm, so they get this well-defined cell membrane, and the color of the cytoplasm also from basophilic becomes eosinophilic, and the nucleus gradually becomes pycnotic and finally it disappears, indicating karyolysis. And these baseloid cells are rapidly dividing cells, so we do expect some amount of mitosis, which disappears when there is then this transition is happening. So these are the 5 changes to observe in this. And there are a lot of tumors which show these ghost cells. There are many odontogenic tumors, and even craniopharyngiomas can also show ghost cell differentiation. And it is also seen in basal cell carcinomas and some of the teratomas and endometrioid adenocarcinomas with squamous morules, and also in the endometrioid carcinoma of the ovaries. So these shadow cells, there are a lot of theories regarding their formation, and some authors believe they are a kind of advanced keratinization or abnormal keratinization. And also some believe they are because of the apoptosis or proteins which lead to this. But the one common thing which has been noticed in all these tumors is beta-catenin mutation in these tumors, which probably is which is probably the molecular mechanism which is contributing to the pathogenesis in these tumors. And we do observe some of the melanin pigmentation because the matrix cells are always associated with the melanocytes, which give color to the hair. And wherever there is a abnormal keratin, we do expect some foreign body giant cell response. And also these tumors are known to calcify. And as the tumor ages, the terminally differentiated shadow cells increase in number, and we hardly find any basaloid cells. So in hair follicle, there are so many varieties of keratinization, and probably this I believe is the 7th type of keratinization in the hair, because cortex and medulla, they also show some keratin and they form a hard keratin. And then the internal root sheath, it keratinizes by forming trichoalin granules. And then we have this outer root sheath which shows tricylemal keratinization, and infundibulum which shows epidermal keratinization, and the germ cells also form some horn cysts. But these matrix cells, they show keratinization in this way, that is the shadow cell keratinization in the hair. BCC with the shadow cell differentiation can be considered as a DD, but again the classical features of basal cell carcinomas are not seen in this case. Shall we move on to our next slide?
Yeah, one question. Where else can we see shadow cells? If I just say hematology, this is for our PGs to answer. Shadow cells, ghost cells in hematology. Yeah, continue.
Good morning, ma'am. I'm Dr. Nandyal.Professor from Department of Pathology, SSIMSRC. Can you please go to the next slide? A 40-year female non-healing ulcer over occipital region since 3 months. From the history, it's non-healing ulcer. So first I will think of squamous cell carcinoma. On the gross appearance, it is it appears well delineated and measures around 3 into 2.5 into 0.5 centimeter. And on cut section, it appears clay white with shiny areas. In this slide shows there are variable sized lobules, and there is epidermal and acanthosis. There is absence of granular layer in this slide. This slide also shows absence of granular layer and epidermal with the cystic formation, and there is abrupt keratinization. The presence of very sized lobules, amorphous keratin, eosinophilic amorphous. This slide shows clear cells, clear vacuolated cell, and this is showing areas of calcification. The features that is having a variable size lobules with epidermal thickening and areas of calcification with few clear cells in compared to say, taking in consideration all the cells. I consider it as proliferating tricholemal cyst, also known as proliferating tricholemal tumor or proliferating pilar tumor. Thank you.
Okay, very well described. Before going to the slide, this was the tumor that is proliferating tricholemal tumor, which was arising from the outer root sheath and also from the isthmus region. So there are so many tumors which are arising from the isthmus. Only few of them show this kind of keratinization, whereas some tumors like tricholemoma, they do not show this tricholemal keratinization. So let us know the two forms of keratinization from the upper segment and the middle segment. So the tumors which are arising from the infundibulum, they show this epidermal type of keratinization, whereas the tumors which are arising from the outer root sheath of the isthmus and the lower part, they show this tricholemal type of keratinization. So this is the infundibular type of keratinization, that is epidermal type, usually which is very similar to that of epidermis. So here the keratinization takes place with the presence of the granular layer, and the classical example for this type of keratinization is trichoadenoma, which is an example for infundibular tumor. Whereas the other type is tricholemal type, which is by the outer root sheath cells, which is kind of abrupt, and it is complete without any granular layer, and it occurs wherever the outer root sheath is not attached to the inner root sheath, because at certain level, as I explained in the histology, the inner root sheath will disappear so it is not there in the isthmus. So the tumors which are arising from the isthmus above the inner root sheath, they show this type of keratinization, and it is very similar to that what we see in the hair cortex. So when we say tricholemal keratinization, it means that the stratified epithelium of the outer root sheath, they get converted into an anuclear keratin without the keratohalin layer, because in the hair we have this keratohalin layer, so no inner root sheath, so no keratohalin layer in this type of keratinization. So that is what we see in pilar cyst as well as in case of pilar tumors. This keratinization, these are the squamous islands which will be covered by the fibrous sheath, and we have these squamoid cells which show palisading at the periphery, and these cells which are actually derived from the outer root sheath, they don't show any intercellular bridges, and the innermost layer of the cells, they they will be swollen, and there is abrupt keratinization without the granular layer, and the keratin what is formed here is compact, and it is eosinophilic. So let us move on to this slide. So as it was well described, so these are the squamous lobules which are showing cystic change, and also we can see some palisading in these islands, which is covered by some fibrous tissue. Here also there is a layer of palisading, and there are some squamous eddies, and we are seeing this abrupt keratinization. Some giant cell reaction to keratin. These are kind of very busy cells, these squamous cells which are proliferating in the tumor. Sometimes if we are lucky, we may find the halin sheath like that we see in outer root layer, but it is not absent here. So another picture of tricholemal keratinization. And sometimes we do expect some amount of dyskeratosis and sometimes mild atypia, which at first glance may mimic squamous cell carcinomas. So area of calcification in some parts of the tumor, which help us in differentiating it from squamous cell carcinoma. So there are 3 varieties of proliferating tricholemal tumor. So group 1 tumors, as in this case, is benign. They do not recur with if at all, there will be very mild atypia. Whereas these low-grade tumors, they are quite irregular and have a pleomorphism. Whereas malignant ones, they are invasive with lot of pleomorphism, necrosis, and mitosis, and they tend to even metastasize and behave aggressively. So in practice, we have to do a proper examination and differentiate these tumors from SCC. So what are the clues to differentiate it from SCC? So if the pilar tumor is arising from the pilar cyst, then our job is very easy. And then these pilar tumors, they have a very good circumscription and pushing margins, and they do show this tricholemia keratinization, which is an important feature. And atypia, if at all is present, it is very minimal. And there will be peripheral palisading in these tumors. As I said, if we are lucky, we can find hyaline basement membrane. And again, calcification is a clue towards pilar differentiation. And a lack of the in situ component and keratin pulse, as we see in SCC. So these are some of the clues. So can we move on to our next slide?
Slide number 3. Case details are 28-year-old female. She has an ulceration over scalp. She had a previous history of hair follicle tumor, which is excised over same region. Ma'am, this is an invasive tumor which is located in the dermis. This slide shows a well-defined lobulated solid tumor which is located in the dermis. Tumor tissue is arranged in lobules, which is separated by fibrocollagenous septate. The next slide is showing there is peripheral palisading of small basaloid cells, and arrows are showing brisk mitotic activity. And there are the other two arrows are showing brisk mitotic activity. The next slide showing well-defined lobulated solid tumor, which is consisting of proliferating squamous epithelium. There is also peripheral palisading of basaloid cells. These squamous cells are showing mild atypia. In this slide, we can see central tricholemal type of keratinization and also individual cell keratinization is seen. My diagnosis is proliferating tricholemal cyst or a pilar cyst, which consists of a well-defined lobulated solid tumor, which is consisting of proliferating squamous epithelium, which is surrounded by thick hyalinized membrane, individual cell keratinization, and also central tricholemal type of keratinization is seen. So my diagnosis is proliferating tricholemal cyst or pilar tumor. Thank you, ma'am.
A 28-year-old female with ulcer. There was a history of previous hair follicle tumor which was excised over the same region. So actually, this was a known case of proliferating tricholemal tumor, and so we can see that there is a invasive tumor in the dermis because there is a lot of stromal desmoplastic reaction. So this case, because epidermis was ulcerated, I just had the photos of the tumor. And in low power, these cells look small, and so in between these cells, we kind of see this pinkish amorphous material between the tumor cells. And also we can see the peripheral palisading in the islands of these squamoid lobules. Also some appreciable atypia and mitosis is there. And there is an area of focal area of necrosis, and this is the area of abrupt keratinization in the high power. So this actually we had made it as a malignant proliferating tricholemal tumor because there was a history of recurrence. Also, if there is a proliferating tricholemal tumor and there is a history of sudden rapid increase in the size, then also we have to think of group 2 or group 3 pilar tumors. Here there was ulceration, there was infiltrative growth, atypia, and mitosis and necrosis. So in kind of we made it as a group 3 tumor. I included this slide because this was the rarest, it is the rarest hair follicle tumor of all times, and real incidence is unknown because there are inconsistencies in nomenclature, and many a times they are misclassified as SCC. So these tend to recur and they metastasize. Of course, there are some IHC markers which can distinguish these tumors like CD34 and calretinine are outer root sheath cell markers which are important in this case. So this particular case just highlights the importance of histomorphological features here. So we could not do IHC because it was like a very old case, 2007 or 8. So this is what we gave, so malignant proliferating tricholemia tumor. So this is next spotter. So anybody, what do you feel it is?
Good morning, ma'am. I am Dr. Aparna,
Yes.
second year postgraduate
Yes.
in SSIMSRC. This section shows epidermis
Yes.
with acanthosis, hyperkeratosis, and parakeratosis over here. And the rete ridges are
Yes.
showing inward bending, and there is a round shape over here. And few areas
Yes.
have parakeratosis with hypogranulosis.
Yes.
And non-parakeratotic region with hypergranulosis over here. This inward bending sometimes is a feature of verruca vulgaris,
Verruca vulgaris. Yes.
but here in the high power, we see there is an intact basement membrane over here, and there is a thickening of the basement membrane, and there is a columnar cell
Yes.
palisading seen with a clear cytoplasm. Because of this, the features
Yes.
suggestive of tricholemoma.
Yes. Very good. Yes. Very good. Very good. So this is a squamoproliferative lesion, and it is in continuity with the epidermis, and the borders are very bulbous and circumscribed, and there are a lot of overlying epidermal changes here. In low power, it mimics verruca vulgaris, but in the high power, what we see is these clear cells which are kind of resemble. Which structure they are trying to resemble here? So clear cells and palisading and the basement membrane. So anybody? So this is trying to recapitulate its histological counterpart.
Ma'am, didn't get you, ma'am.
Okay. I just wanted this feature to be noticed. Okay, we see this clear cells, palisading of the columnar cells and hyaline basement membrane in outer root sheath. Right? Just it resembles the outer root sheath with this hyaline basement membrane. So this slide, a particular slide I had put to show you another tumor which is arising from the isthmus and the outer root sheath. And do not show any tricholemon type of keratinization like we saw in the pila tumor. And yes, of course, DD is verruca vulgaris, so we have to look for viral cytopathic effects which are kind of absent here, and these clear cells are glycogenated, so they will be PAS positive. And there are skin adnexal, other skin adnexal tumor which shows clear cell changes, this clear cell hydradenoма, and other skin adnexal tumors which can show such hyaline basement membrane material is cylindroma, which kind of has a jigsaw puzzle pattern, also known as Duffin tumor. Yes. Can we move on to our next slide?
Yes. Here there is an 86 years old female showing who is asymptomatic nodule over the dorsum of the nose.
Okay.
This section studied shows epidermis with a basket with keratin over here, and in dermis there is a well circumscribed lesion with islands of basaloid cells with fibrocellular stroma seen over here. And this is the true horn cyst showing epidermal differentiation with mature keratin inside. And this section shows that island of basaloid gel with a palisading pattern around. And here there's a cribriform pattern over here in the corner. Here there is this section shows fibrocellular stroma around, and there is a round to ovoid stromal cell pushing over here, known as and this is known as papillary mesenchymal body. And all these features
Yes, very good.
of trichoblastoma.
Okay, fine. Thank you. That was wonderful. So let us move on to this slide. So as it was well explained, this is a very well circumscribed tumor which is located in dermis, and at this low power we can see three things. One is the basaloid cells, and there is keratin cysts, and and if we observe these keratin cysts, they are lined by squamous cells which have eosinophilic cytoplasm. Yes, there are many of them, and also we can also appreciate the peripheral palisading here in the basaloid cells, and they are very closely associated with the stroma, and also some hair formation we can make out. This particular structure, it is trying to mimic hair bulb. So this is the papillae, like invagination into these basaloid islands, and they kind of these recapitulate the hair bulb. So these particular structures are called as papillary mesenchymal bodies. So back to our classification. So this particular tumor, which is of germ cell origin, so it originates from the hair bulb, where there is a layer of palisading germinative epithelial cells which are in close association with the papillae. So that is why the tumors which are arising from these germinative cells, they have this biphasic differentiation. So they have both epithelial as well as mesenchymal component. And the characteristic features of such tumors are finding these basaloid aggregates with palisading and fibrotic stromas, keratin cysts, and these classical papillary mesenchymal bodies. So these are various papillary mesenchymal bodies. If we are very lucky, we see them. Like these are the basaloid islands with palisading, and they are closely associated with the stromal cells. They are at various levels of section. So if the section is taken like this, so sometimes there are chances that we see only stromal cells and miss these basaloid islands. So the tumors with this type of differentiation are only two varieties, that is trichoblastomas and trichoepitheliomas. So distinguishing these two tumors is very difficult because they exist on a spectrum. But sometimes whatever name we give to these tumors really doesn't matter because both are benign. But we call them as trichoblastomas when they are very large and they are located deep in the dermis, and they usually lack connection with the epidermis. But we call them as trichoepitheliomas when they are very small, like in this case, like a small papule, and it is superficially located in the dermis and have plenty of horns. Okay. So a very close DD for these germ cell tumors is of course basal cell carcinomas. So how we can distinguish them? So this is a case of basal cell carcinomas. So they also have peripheral palisading here and basaloid cells, but we have to identify these retraction artifacts, the stromal retraction artifacts, as well as mucinous change in the stroma. And so these PCCs are attached and connected to the epidermis. They can cause surface ulceration. Definitely, these basaloid cells have atypia, and they do show mitosis. Of course, there are IHC markers to distinguish between these two, because it is very important. Epitheliomas and blastomas are benign tumors. So they don't undergo any surface ulceration. There are no clefts here, and we can see these islands are surrounded by the spindle-shaped stromas, which kind of mimic hair follicles. So that's the classical fibrotic stroma of these tumors. So this is basaloid tumor. It is connected with the epidermis, and also we can see there is a clefting, there is a mucinous change, there is a lot of mitosis and atypia. So very clear cut, we can say this is a basal cell carcinoma. So since there was another DD which was given from your side, that is microcystic Adnexal. Let's put one slide so regarding how to differentiate this. Microcystic Adnexal carcinomas are sclerosing sweat gland tumors. And these are not DDs for trichoepithelioma, a conventional variety. But if there is a desmoplastic trichoepithelioma, then definitely It has to be distinguished from these MAC lesions. And if the biopsy is taken superficial, it is very difficult because microcystic adnexal carcinoma is a deeply invasive tumor. And again, though it is a sweat gland tumors, there are a lot of keratin cysts within these tumors. But somewhere in some areas, these do show ductal differentiation and shadow like ductal structures. And the stoma is highly desmoplastic. So if the biopsy is superficial, it becomes very challenging and confusing to distinguish between them, especially the desmoplastic. So there are some. So today we saw 3 adnexal tumors which show peripheral palisading. Right, in this case, that is germ cell tumor, trichoblastoma epithelioma, then pilar tumors and tricholemomas. Also cylindromas and some of the sebaceous adenomas and sabeshomas also can show peripheral palisading. Also, like understanding some terms is very important for the interpretation of the findings. So for the PGs, I have just added 2-3 slides about these keratinization areas, which is a common area of confusion. So just to clear the concept, so what are these horns? So these are rounded structures and they have central keratinous material, and they are surrounded by the keratinocytes. It could be baseloid cells or even eosinophilic cells. Either they can be located in the epidermis or in the dermis, and these show laminated keratin, and they show abrupt keratinization, but it is complete. So there is no nuclear remnants in these horns, and the pseudohorns kind of communicate to the surface. So we do see them in a lot of skin adnexal tumors. Apart from that, it is seen in seborrheic keratosis and even in keratotic variant of basal cell carcinoma. So this is the seborrheic keratosis horns. It is lined by baseloid cells, and it is within the epidermis. Whereas the keratincysts or horns in the adnexal tumors are usually dermal location, and they can have both baseloid as well as eosinophilic cell lining. And then about the horn pearl or a keratin pearl. So these are kind of trapped keratin within the invasiveness of squamous cell carcinomas, because these are the malignant cells with lack cohesion, and they kind of get arranged in a concentric manner. And the keratinization here is incomplete because there is a retainment of the nuclei, and these are usually located in the invasive islands in the dermis. And the keratin is very dense pink, and it is surrounded by the malignants. So whereas these squamous eddies, we do see them in various lesions, like even in adnexal tumors. Today we saw them in proliferating tricholemon tumor. So these are the circumscribed eosinophilic flattened squamous cells, and they are having a whorled arrangement in an onion peel fashion. And there is no keratinization in the center, and these cells lack ATP. So it is seen in pilar tumors like proliferating trichomonas, and there's even in a desmoplastic variant of tricholemonas. So can we move on to the next spotter? Fatima?
Yes, ma'am. Spotter number 2 usually presents as a solitary nodule in the head and neck region with a central tuft of fine hairs protruding out of it. Can you see my slide, ma'am?
Yes.
Yes.
Yes, I am only focusing the slide. I think you can describe.
Yes, ma'am. There is a well-defined cystic lesion in the dermis, which is consisting of a centrally located cystic hair follicle. The central follicle is showing keratotic debris, and there are numerous secondary and tertiary hair follicles, which are branching out from the central cavity into the fibrotic stroma. The next slide is showing the cystic cavity, which is lined by stratified squamous epithelium. At few places, a granular cell layer is seen. Cystic space contains loose keratin. The next slide is showing baseloid arrangement of hair follicles, which is consisting of immature and malformed hair follicles, which are present in the dense compact stroma. In this slide, we are seeing numerous secondary and tertiary hair follicles at different stage of development. The secondary hair follicle is showing a hair papillae which contains a keratohyalin orange granules, which is inner hair root sheet, and we can also see an outer hair sheet consisting of clear cells. So considering all these, my provisional diagnosis is trichofolliculoma.
Okay, thank you, Fatima. So this is a spotter too. This is the classical clinical picture. So they present as a small nodule in the head and neck region, and a small tuft of hairs that kind of protrude out of the central hole. And these tumors are located in the dermis, and we can see that there is a large central cystic cavity. At this section, we are not seeing its connection with the epidermis, but usually they are connected to the surface epidermis. And the central cystic cavity shows a epidermoid kind of keratinization. So this is the dilated primary follicle, which is lined by epidermis, and it shows granular layer and epidermoid type of keratinization. Whereas from the wall of this mother follicle, you can say, so the small baby follicles, baby hairs can arise from the surface, like we call them as secondary follicles, and then again they can give rise to tertiary follicles also. So these recapitulate various anatomical lines of differentiation of the hair. Here the whole hair has been formed. This resembles like a hair bulb, and also the inner root sheath is formed. We can identify them with the color of the granules, and also there is it is covered by an outer root sheath. Also, we are finding some keratinocysts, and there are basiloid cell islands here. Some are arranged in cords, and they are connecting the hair follicles which are arising from the wall. So these are secondary follicles. Again, they are dividing into tertiary. It so happens that the secondary follicles involute, and the newer tertiary follicle can come from the surface. So I included this in order to, for the completion's sake. So this is a tumor with a pan-follicular distribution, differentiation, and many authors believe that consider them as hematomas, but these have some hair follicle stem cells, which has been proved by IHC. So usually occurs on the head and neck, and they can show different morphology of the hair cycle, like we saw from anagen hair follicle here. This is just developing. So there can be various spectrum of the hair cycles here. And the hairs which are arising are small vellus hairs, and they are kind of distorted also. So this particular tumor, like there is a large cyst which is connected to the epidermis, like what we see in trichofolliculoma, which has a dilated follicular orifice. There are two other tumors which also resemble the same. So they have a large central cystic cavity, and but how to differentiate this is in case of dilated core of Weiner, which is an infundibular tumor. So that central cystic cavity is lined by epidermis, but it has some the retail-like extensions from the epidermis. Whereas in case of pilar sheath acanthomas, again there is a large central cystic cavity which is showing epidermal keratinization, but the wall has nodules of these eosinophilic cells resembling the root sheath. So these two are considered as a differential diagnosis. So we had another case. So this is another case of trichofolliculoma, which I had seen recently. Again, there's a large central cystic cavity, and from the wall we can see some hair structures which are arising, and these are associated even with the sebaceous glands also. And we can see some rudimentary hair follicles and keratin cysts. Okay, so the branching also can be made out. So maybe a few people may consider a dermoid cyst as a differential diagnosis, but in case of dermoid cyst, the structures which are arising from here are mature adnexal structures, and they also have, along with the hair, and they have sebaceous glands and eccrine and apocrine glands. There are no rudimentary structures, no basiloid proliferations, and no keratin cysts in case of dermoid cyst. So that was about trichofolliculoma with panfollicular differentiation. So can we move on to our next spotter?
Yes, ma'am.
So what do you think it is?
A warm good morning, Honorable Ma'am and Sir. I am Dr. Pranjal Nath, second year PG SSIMS and RC. So I'll be discussing this
Okay.
tree and so I'll be discussing the spotted tree that has been put to me. So this picture shows a distorted hair follicle which is surrounded by a dense basically fibrous tissue and some bands of collagen, bands of fibrous tissue are extending into the stroma. So I would like to go with the fibrofolliculoma.
Yes, very good. So what we can see here is there is a distorted follicle, and from the wall there are some basaloid anastomosing epithelial cells which are arising from the wall, which are anastomosing. And also we can see that this distorted hair follicle, it has its own stroma, and it is different from the dermis. And in the high power, we can see there is these basaloid cells which are arising from this follicle. And the stroma here, which is fibrous, and this stroma can be differentiated then by the dermis by the loss of elastic fiber. So this is absent here. So this is an example of our last hair follicle tumors, that is the fibrous tumor of the follicle, which is arising from the outer fibrous sheath of the hair follicle. Again, closed EDs, trichodiscomas, but here we usually see some small telangiectatic vessels along with this, and the connective tissue is finely fibrillar. Again, there's a lot of morphological overlap between these two tumors. So for the completion's sake, I had included this case, an example of a benign hair follicle tumor with the fibrous sheath differentiation. So can we move on to the next slide?
Slide number 5 is a 19-year-old male solitarily raised scalp lesion. So here we can see the sebaceous glands are undergoing hypertrophy. There is a distortion of the hair follicle with papillomatous outgrowth. So also few immature hair follicles are present here. Some features of acanthosis are also present.
Can we see the slide?
With sebaceous hyperplasia. Closes due to presence of papillomatosis. Closes due to the presence of epithelomatosis and ill-formed hair follicles would be nevus sebaceous of the Jadahorn.
Now?
Yes, ma'am. Now visible, ma'am.
Okay. So let us move on to our next slide. So the history given here is a 19-year-old male, and there is a solitary raised scalp lesion. So this is a puberty age lesion, and what we can see here is the epidermal changes, which are very characteristic. So there is an acanthosis of the epidermis, and we see a lot of sebaceous glands. And at few areas there is a papillomatosis and hyperkeratosis, and there is a infundibular dilatation. Yes, so this is a scalp lesion, and some areas we see a lot of sebaceous glands with a lot of hyperplasia, and these sebaceous glands at few places, they are directly opening to the surface. Normally, sebaceous glands open into the hair duct, but here they are opening directly to the surface. Some immature hair structures are seen, and also, there's a dilated infundibulum, and these sebaceous glands are directly opening to the surface. Here also, some of the glands opening to the surface. And this is an immature hair structure, and we do see some dilated ducts, sweat ducts here. And if you closely observe at low power, they look like eccrine ducts, but some of these ducts are showing a decapitation secretions within the limb. So this is a scalp lesion, and we are finding apocrine-like glands in the scalp, which are actually not seen in the scalp lesion. And also, if we carefully observe in the whole lesion, mature hairs are absent. Only in the periphery, some hairs we can see. So there is a loss of mature hairs and sebaceous hyperplasia and epidermal changes. And sebaceous glands directly opening into the dermis, and we kind of have dilated ectopic apocrine glands, because in the scalp we don't see this lesion. So wondering what this lesion could be. So this is nevus sebaceous, which is a hematomas. So if this biopsy, if it was done in a childhood, maybe the lesion would be missed because the sebaceous glands are underdeveloped in childhood. And the characteristic features are only seen in puberty, like the size and the number of the sebaceous glands are increased, and it also gets the classical verrucous appearance. So at the adult stage, there are a lot of Adnexal tumors can arise from this nevus sebaceous, like trichoblastomas, syringocystadenoma papilliferans, and so on. So this is nevus sebaceous, which is a hematoma of the sebaceous gland. So also the classification of the sebaceous tumors, we have benign and malignant ones. Benign are adenomas and subluxomas, and malignant we have sebaceous carcinoma. So that was nevus sebaceous. So there are a lot of entities. Whenever we hear the name nevus, we usually think it is a birthmark or the melanocytic nevus, or if the lesions are present at the very young age, also we can call them as nevus. There are a handful of lesions with the name nevus in the skin. There is hair follicle nevus, epidermal nevus, eccrine nevus, and so on. Okay, shall we move on to the next slide?
Slide number 6. The history given was 55-year-old female with nodule over the nose. This section shows a well-circumscribed tumor in the dermis with areas of basaloid cells, and the arrow pointing towards some sebaceous secretion. In this section, there are two types of cells in basaloid cells and scattered clear cells. The arrow pointing towards the scattered clear cells and the basophilic basaloid cells. This section mostly shows the basaloid cells. This shows the clearer, scattered clearer cells. Looking to all the features like areas of basaloid cells and scattered areas of clear cells with some sebaceous secretion, features suggestive of sebaceoma. My deities for this are sebaceous adenoma or sebaceous carcinoma. Thank you.
Okay. Thank you. Before going to the slide, let us just know about the sebaceous glands. So the sebaceous glands are there everywhere, but they are absent on the palms and soles, because we know they are always associated with the hair, be it terminal hairs or the villus hairs. So the size of the hair doesn't matter, and these open into the hair ducts, and usually we see 1 or 2 layers of outer germinative cells, and then these mature into these sebaceous sites, and they show this holocrine secretion, that is the cells disintegrate and release sebum into the duct. Okay, so this is how the holocrine secretions look, and like a pink amorphous material in the duct. And okay, this is the tumor, and this is located in the dermis. I had very few pictures of this slide. So what we can appreciate is there is a lobular pattern, and there are two types of cells in this power. Okay, so these are basiloid, and these are the foamy cells. And these cells also, they are recapitulating that holocrine process in these tumors also. There is a lot of pink amorphous material here in these within these islands, and yes, the holocrine secretions are there. And so the undifferentiated cells, and we have to look for the proportion of these undifferentiated cells and the mature cells. So if you look in this picture, usually the proportion is almost equal, but here we do see that the basiloid cells are outnumbering the mature cells. So that differentiation between sebaceous and sebaceous adenoma, I feel it is arbitrary. So whenever we see basiloid cells are more than 50%, so we call it a sebaceous, and if the mature cells are more than 50%, we call it a sebaceous adenoma. So they exist on the end of the spectrum. So whatever you call it, I would like to take it, because the whole tumor should be taken into consideration in order to see the proportion of these cells. And in case of sebaceous hyperplasia, usually the basiloid cells are limited to 1 or 2 layers of these sebaceous globules, whereas in case of adenoma, there is a slight increase in the basiloid cells, whereas in sebaceous, you can see basiloids are more than the mature ones. But whatever is the lesion, that holocrine process of secretion is being recapitulated in all these tumors. And also, this amorphous material, which is seen in these tumors, should not lead to overinterpretation of tumor necrosis. And also, it should not be confused for keratinization, because it can lead to overdiagnosis of malignancy in such conditions. So that was to highlight the holocrine secretions within the tumor. Okay, so our last slide.
Swelling in the lower eyelid in a 78-year-old male, it might be lesion. Swellings in the lower eyelid can be either basal cell carcinoma or squamous cell carcinoma, or it can be sebaceous carcinoma. Considering the age and repeated recurrent cause for the tumor, it might be sebaceous carcinoma. And sebaceous carcinoma can be confused with chronic blepharoconjunctivitis. Here we can see there are irregular epithelial lobules with infiltrative growth in the dermis. Slide 1, 2, 3, and 4 shows there are infiltrative growth in the dermis. Here we can see differentiated and undifferentiated sebaceous cells with nuclear atypium and mitotic figures, and there is nuclear pleomorphism. My diagnosis is the sebaceous carcinoma, and it has to be differentiated from basal cell carcinoma and squamous cell carcinoma. In squamous cell carcinoma, there will be squamoid cells and keratin pearls. And IHC marker to be differentiated are EMA, anti-PCA 255, and CAM can be used to differentiate between three of them. Thank you.
Thank you, and you made my job very easy. So yes, this was a small biopsy from the eyelid, and we do see that there is some squamoid looking cells and some clear looking cells here, which are arranged in irregular lobules of varying sizes, and many cells are appearing undifferentiated, but in between them we do see some clear cells or vacuolated cells within the tumor. Yeah, there are mitosis and that foamy vacuolated cells we are able to appreciate in some areas. Yes, can you see the foaming cytoplasm of these cells? Yeah. So this is what is this stain? So the sebaceous cells, they do contain something, no? Because of their foamy appearance. So what is the content of these cells? Yes, lipids. So this is a oil red O on a frozen section. So these sebaceous tumors are positive for oil red O. Yes. The sebaceous carcinomas of the eyelid are very aggressive, and they do arise from these meibomian and these glands. And the closed DDs are, as you said, clear cells, squamous cell carcinoma, which shows evidence of keratinization. And BCCs, of course, have the typical features of BCCs. But in any of these tumors, we don't find these classical foamy cells. And so distinguishing it from sebaciomas, so we need to look for infiltration, atypia, mitosis, and necrosis within the tumor. So that was sebaceous carcinomas, and as you said, it is a great mimicker, so it mimics a lot of inflammatory conditions of the eyelid. So I have to be very cautious in recognizing these tumors. And yeah, so diagnosis of these follicular sebaceous tumors seem very difficult, but now I think it is achievable now with proper knowledge of classification based on the anatomical lines of differentiation. And please do not forget that histopathology is the gold standard, and despite the use of expanding use of IHC. And many a times we try to give a specific name to these Adnexal tumors, but it is only of academic interest, because sometimes surgeons and pathologists, they are more interested to know whether it is benign or malignant, more interested in the nature of the tumor. So once it has been removed. So, but definitely the study of these tumors is very interesting and fascinating. So I hope I have done justice with these slides. And if any doubts, if time permits, I can take questions.
Hello, Nimsha.
Yeah.
No.
Any questions from the audience? So I hope there are no questions, and we have also exceeded time. Myself, Dr. Nismak has, and yes, ma'am. Doctor. Good morning, sir. Is Dr. Murthy sir is here? I hope he has out. So yeah, I would myself, Dr. Nisma Hassan from SSIMS. It feels honored to extend the vote of thanks to Dr. Sonam and Nandyal ma'am for giving us such a wonderful session on the Pilosebaceous tumor. So this was not a very easy topic, and ma'am has actually enlightened us as how to approach the tumors and come to a diagnosis. And also she has taken a lot of effort in explaining the terms. So thank you very much, ma'am. I would like to thank Dr. Shashikala ma'am for initiating such an session and for being a backbone of our virtual slide seminars. I also extend my gratitude to Dr. Kavita ma'am and Dr. Deepti Prithvi ma'am for actually making this session successful, and to all other faculties who have joined their hands. Academic sessions are not complete without the participants, and I would like to thank all the PGs from SSIMS and Basaveshwara Medical College for actively participating and making it. Thank you, everyone. And also, I would like to extend my thanks to the other participants and also delegates who has been here from the beginning to the end. And
request everybody to be on video mode. Let us take a picture.
Yeah, I would request everyone to come on the video mode because we are trying to take a picture.
Sorry, I can't.
Yeah.
I can't do this. Please don't call me for this.
You can try. Screenshot. Yes.
Koda.
I want that slide at least.
Yeah. Thank you, ma'am. Thank you, Sonam ma'am and Shashikala ma'am and everyone for this, for involving us in this. Thank you.
We are not able to see your face today.
Yeah. Can you see now? Yeah. Yeah, yes. Nice. After a long time, getting involved in the college activities. Yeah.
Stop sharing. Sonam, stop sharing the slide and let everybody come in.
Yeah.
So that we can have. Put that
Okay.
Just direct message. Everybody. Please.
Slide seminar. Slide seminar ಏನಿಲ್ಲ. ಹುಷಾರು. ಸ್ಲೈಡ್ ಸೆಮಿನಾರ್ SS ಹಾಸ್ಪಿಟಲ್ ಇದು ಕೇಸ್ ಡಿಸ್ಕಷನ್ ಮಾಡ್ತವ್ರೆ. ಲಿಂಕ್ ಕಳಿಸಿದ್ರು.
ವಿಡಿಯೋ ಮೋಡಲ್ ಬನ್ನಿ.
Just
more.
Actually,
Now, oh yeah.
Thank you, HOD ma'am, Kavita ma'am, Deepti ma'am, Rajeshri ma'am.
Lakshmi is there.
It was awesome. And the first slide we learned from ma'am PG days was Phylomatricoma. And I was asked to diagnose recently, which I had later while riding, I could pick it up. Whatever we have learned is from SSLMS Patho, and our department rocks and we miss it, ma'am, we miss it. There is life there, lifeless here. Awesome session, ma'am. Hope to have many more in the future. And PGs, whoever have gotten admitted in SSIMSRC are really, really, really lucky. I mean, nobody gets so much of teaching. Out of the college and college, people only we get to know we're learning in the SS Medical College. Nowhere else, take it from me, nowhere else they teach so much. Whatever I've learned is from HOD ma'am, Kavita ma'am, Deepti ma'am, Rajeshri ma'am, Sonam ma'am, and everybody there. Thank you so much. Thank you so much. Thank you so much.
Hi, Asha. Ramaswamy is also there. Then Sridevi. Malika is not coming in video mode. Then she's there. Sridevi.
many of them are known.
Jagadishwari. Jagadishwari. Next is your turn.
ఈరోజు చూపుతారా?
Go actually. Here we have. I think it's
Screenshot.
Yeah.
So we get Thank you all for making this academic program a success.
Thank you, ma'am. 3 cheers to SSIMS Patho department. Good time. Hooray!
Thank you.
Thank you, ma'am. Thank you so much for this session.
Thank you.
We want each one of you.
I also.
Yes.
Finally, I would like to thank our beloved HODs Murthy sir and Shashikala madam for this opportunity, and I thank all the staff of SSIMSRC and also my colleagues for the support and all the PGs for their active participation. All have done well. Thank you.
Thank you.
Thank you, Sonam.
Thank you, ma'am. Thank you, ma'am.
Thank you. Thank you, ma'am. Yeah. Okay.
Good beginning. Thank you.
Thank you. Can I end, ma'am?
Bye.
Recording, yeah.
Yeah.
You have to save it, no?
It says
Yeah.
it's only
Should I?
Yeah,
But recording should be stopped.
Ma'am, snacks beko.
Lakshmi.
Asha, snacks, Asha.
ಹೌದು
Samosa
ದಾವಣಗೆರೆ
ಬೇಕು ma'am,
ಮಿಸ್ಸಿಂಗ್ ದಾವಣಗೆರೆ ಸ್ಪೆಷಲ್
It's